Dr. Beverly Reed.
And I'm Dr. Amber Klimczak.
And we are
Two Peaks in a Pod.
Well, hi, welcome back, everybody. Have you had a good week?
Yes, we're trying to get into the groove of life back at work.
Okay, well, I thought maybe today we could talk about the big head-to-head competition between Clomid and Letrozole.
Yes.
I always get this question at my new patient consults when we're trying to formulate a plan for my patient, and they always want to know, why are you choosing one of these medications over the other? Because I do usually have a preference for one over the other. And so I thought we could kind of talk about all the reasons why. But first, let's talk about why we would need to use these medications. So can you tell me kind of why you like to use them?
Definitely. And before we get into this whole discussion, I want to preface this by saying we're talking about with your initial plan when we're just trying to estimate what is the best drug for you, which one we will try maybe first or for your first few treatment cycles, right? A lot of times I bounce back and forth between these drugs. So before we get a bunch of comments and questions, Dr. K, you said one thing on your podcast, but you're doing the opposite for me. Well, this is what we think, right? Based off of just like the traditional patient populations. Okay. So we do go back and forth.
It is so funny you say that, because I do get that comment a lot from people. People will go, "Oh, well, I listened to your podcast on this," and I thought, "Oh God, what did I say?" I don't remember. Sometimes we filmed these so long ago. So we are always trying to do our best in any moment, but sometimes things can things can change over time. And remember, we are always trying to customize things according to your body,
right?
But these are just kind of generalizations. Overall.
Yes.
Okay. So,
so I would say the most traditional time that you'll see us using these medications in the fertility setting would first be patients who don't ovulate at all, right? That's really what these medications were kind of developed for. Actually, one of them was sort of by mistake, right? But we are looking at someone who on a regular basis is not getting a cycle every month, and we suspect that they're not ovulating, and we want to try and get them to induce ovulation. And so that's the most common time that we'll be using letrozole or Clomid. But every once in a while, we have patients who are already ovulating and they're still not having success at getting pregnant. And so we might want to give them one of these medications to try and induce them to ovulate more than one egg in 1 month in an attempt to increase pregnancy rates.
Absolutely. Okay, you mentioned a mistake. They found this out by mistake. I don't know about this. Can you tell me?
Supposedly, someone can Google this, but I think the history behind Clomid or clomiphene citrate, one of the really common and longest used medications in the fertility world, was that they were trying to develop a birth control, right?
Really?
I
didn't know that.
Yeah,
and they accidentally got people pregnant.
Yeah, I think so. Someone Google it and let me know. Fact check me, but I think so.
Yeah, well, maybe that will make more sense when we think about the mechanism.
Yeah.
Now I can understand that a little bit better. Interesting. Okay, well, I think when you were explaining who you would give these pills to, I think it's helpful for us to really distinguish between those goals. So for some people, we're trying to get them to go from 0 to 1 egg that they're ovulating. Whereas for other people, we might be trying to go from 1 egg that they already ovulate on their own to maybe 2 or 3. Super ovulation is what we call it, to try to give them better chances of being able to get pregnant. For patients, a good way for you to kind of know which category you would fall in is looking at your menstrual cycle history. If you are not having periods, then you're probably not ovulating. Or if your periods are unpredictable and or irregular, you are probably having ovulation problems. Okay. Whereas if your periods are like clockwork, every 28 days, every 30 days, 95% of the time you are ovulating. And so I think that can help kind of distinguish between those two.
Yeah.
Okay. We got to go back to school and we've got to talk about the mechanism of action for each of these medications. So I guess we can start with Clomid and maybe why that had made sense to me, that maybe they were studying it to be a contraception and then found out that it didn't work that way. And, in the fertility world, we love our acronyms.
Yes.
And so the acronym for the mechanism of action for Clomid, it's called a SERM, which is a selective estrogen receptor modulator. And I think when they probably first started studying it for contraception, they said, gosh, if you can find something that blocks the estrogen receptor, it makes sense that that could keep somebody from getting pregnant. But then what they probably didn't realize is if you block the estrogen receptor, the brain can say, wait a second, something's going on here. And it starts trying to fix that. And I think probably the thing to understand first, which I think is so cool, is that our brain and our ovaries talk to each other.
Right.
I mean, is that not amazing? And so the way they talk to each other is our pituitary gland makes FSH and LH, and those are hormones that tell the ovaries what to do at any given time. And then the ovaries make hormones that feed back to the brain to tell the brain, did I do the job that you wanted me to do or not? And so what Clomid does is it blocks estrogen. Okay, so the brain thinks there's no estrogen, and therefore the brain says, gosh, I really need to stimulate the ovaries to start making estrogen. And so that is how Clomid works. And that's why it's so effective in getting multiple eggs to grow.
Right. Yeah. And the way I describe this to my patients is that Clomid and Letrozole basically get to the same endpoint,
Yeah.
but by different routes,
Mhm.
right?
Mhm.
So Letrozole is an aromatase inhibitor. That's a little enzyme that you have in your body that actually is involved in creating estrogen. And so when you block it, you're not making as much estrogen. And so then you don't have that feedback to your brain to say, hey, you have sufficient estrogen around. So your brain panics and releases more of those hormones, those keys to talk to your ovaries to get them to release more, basically to give your ovaries more stimulation. Okay. They do it in different ways, but ultimately we're trying to get more FSH to grow more follicles. FSH is kind of that key to the ovaries to unlock more follicle development.
You know, this kind of reminds me, as you're explaining the mechanism, of a patient that I saw recently. Okay, so you're going to be shocked when you hear this. So this patient said, I've been seeing a functional medicine fertility doctor, and they've been giving me letrozole, and it's not working. Okay. And so I'm like, okay, you know, what dose are you on? And we're trying to work out the specifics because it's pretty unusual to have somebody who just won't respond at all, you know? And she said, okay, well, I take my letrozole 2 pills a day, and then that's when I start my estradiol pills. And I said, surely you must be confused, right? Like, you wouldn't take letrozole and estradiol at the same time. She said, well, yeah, that's what my doctor told me to do. I said, are you sure this person's a doctor?
Yeah.
Because here's the thing, you are totally canceling out the effect of letrozole if you give estrogen at the same time. And really, that's when you have to know that mechanism of letrozole. If letrozole works by making sure your estrogen is low, so that your brain detects that and stimulates the ovaries, then if you give estrogen, then your brain is not going to get the signal that there's low estrogen, and nothing is going to happen. And I was just so surprised to see that somebody who claims to be a specialist would not realize that or know that, you know?
Yeah, I've seen that too. Actually, about 6 months ago, I had a patient that was like that.
Yeah.
But it's such a nice patient to fix.
Yeah, I know. Like, funny what happens when you give it the correct way.
Yeah.
But I will say that's very different because maybe, again, some people might be, well, Dr. Reed, you gave me letrozole and estrogen. Okay, but I do it in a stepwise fashion, meaning first I give you letrozole so that you grow your eggs, and then sometimes I'll add a little estrogen just at the end to thicken the lining if needed. How do I know if you need that? I do an ultrasound to check your lining. That is okay to do because at that point, the letrozole already did its job to grow the eggs, and you're just kind of tweaking things at the end.
Totally.
Perfect. Okay. So let's talk about dosing, and I'll be interested to hear what you have to say this because I feel like sometimes you're a high doser on medication.
No, actually, it wasn't until I met you that I really dosed up letrozole. That is a true statement. I was like, oh wow, people really dose around here.
So what are kind of factors you think about? So let's say, you've got your patient and they say, okay, Dr. K, what dose are you going to put me on? Whether it's Clomid or letrozole, how do you determine what dose to give them?
Yeah. Well, let's start with letrozole. Okay. So letrozole is typically given in 2.5 milligram pills. So we kind of think of the starting dose as 2.5, or that's kind of the lower dose. Kind of we think low, medium, or high doses. That's kind of how I used to approach it, right? 2.5, 5, or 7.5. Those were traditionally really the only doses that I would give patients. And based off of, where I trained and experience with a lot of people maybe not responding and having to bump up to 5, I actually very rarely start people at 2.5 milligrams of letrozole. It's kind of opposite. So, the more sensitive we think you're going to be, the lower dose we're going to give you of a medication. Okay. So if we think you're going to be harder to respond, we're going to put you on a higher dose. So that's kind of how I approach it. How severe does your PCOS look, right? What's the anatomy of your ovaries? Does it look like you're really insulin resistant? Does it look like you have a lot of androgens around in that compartment of your ovary? So we kind of look at you as, the whole picture with your PCOS or your other condition causing anovulation, see how resistant do we think your ovaries are going to be. And that kind of helps me to dose them. Now, I do have patients that won't respond to 7.5, and I used to move to injectables, but then I realized Dr. Reed goes up past that and has success, which I think is actually a much safer and nice thing to do. So we will go up past that higher dose quite a bit if a patient isn't responding.
Yeah. So for letrozole, we'll even sometimes go up to 4 pills a day or 5 pills a day. So that would be 10 milligrams or 12.5 milligrams. Now, here's the thing. We would never start at a dose
Correct.
that high. And so that's what I kind of always am explaining to a patient when we're treating them. This is to help you get pregnant, but it's also to help you learn more about your body as we go along. And so I agree. I'll usually start at a 5 milligram, which is 2 pills a day. But I bring them back for an ultrasound. And if they didn't respond, then I give them 3 pills a day. And if they didn't respond, then 4 pills a day. We stair step up to the dose that is going to work for your body. And some things I'll factor into is weight. If somebody is very small, I'll usually kind of be more prone to give them a smaller dose. Or if they're very young, I'll usually give them a lower dose. Or sometimes patients will tell me, look, I'm worried about taking medication. I want to be on a really low dose to start with, or I'm really scared of the risk for multiples. I want to be on a really low dose, right? I kind of factor all these things in when I'm deciding on an initial dose as well.
Right. The higher we go, we're, thinking there's more of a risk that you might develop more than one follicle, right? And that puts you at risk of having something like twins or higher order pregnancies.
Yeah. But I also think too, the higher we go, sometimes the more prone we are to either side effects that the patient's going to have or side effects we see in the uterus and all of that too. So I think that's why we're really thoughtful with trying to just find the right balance. But I think you and I have both been surprised sometimes. Sometimes somebody you would think would just need a teeny tiny dose will sometimes need a huge dose and vice versa, So part of it really is just testing it out on your body to see how you do and how you respond. But that's why I think monitoring is so helpful. I know sometimes when people are taking fertility pills, they're doing unmonitored cycles. And I always feel like, gosh, you're missing out on so much good information.
Right. Monitoring meaning us doing ultrasounds to look and see how many eggs or follicles are you growing? How does your lining look?
Yeah. What about Clomid dosing? How do you decide on that?
Yeah, if I'm going to be using Clomid for a patient that maybe is not ovulating at all, then I would consider the lower dose of Clomid, which is typically 50 milligrams, although that's not my first treatment usually. I usually try and do letrozole first, but maybe I don't like the response on letrozole for some reason. I might try 50 milligrams of Clomid. Now, if you were a person that's already having cycles and I think you're ovulating, I typically would not give you 50 milligrams. I typically will start at that 100 milligram level of Clomid. So that's like 2 pills because, again, I'm trying to give you a little bit of extra oomph in order to get you to release more than one egg because you're already releasing one on your own.
Absolutely. I'm the same way too. Usually in cases where we call it unexplained infertility, especially if the patient is 35 or over, I tend to do 100 milligrams too. But if I have patients that are really young, I do kind of stick with that 50 milligrams. You just don't want to end up in a situation where your poor patient has taken medication and then you have to cancel them for too many follicles. So it can vary from doctor to doctor, but usually if I see 4 or more large follicles that I suspect may have eggs in them, I cancel because I don't want my patient to be at risk of quadruplets, quintuplets, or anything crazy like that, right?
Yeah.
Let's not do that.
Yeah.
Okay, I wanted to kind of mention one of the differences between Clomid and letrozole that I've seen because I know not all providers are comfortable prescribing letrozole. I know for us it's so standard. But I've worked with fertility doctors who aren't comfortable prescribing it and some OBGYNs. And I did want to say why I think that may be reasonable to allow them to do what is comfortable for them. And that is because Clomid is our old trusted friend. Okay. It is FDA approved for this purpose, okay? And we've been using it for way longer, lots of safety data on it. And because the government has given us the stamp of approval, most providers feel very comfortable offering you this medication. But letrozole is not FDA approved for this purpose. And that is important for patients to know that as doctors, sometimes we use medications and we call it using it off label, saying, look, we know that's not what the primary intention of the medication was, but we're going to use it for this other purpose instead. And so, because of that, some people don't feel comfortable doing it. Now, I will say in the fertility world, we use so many different medications off label, right?
Yes, very
Yeah,
commonly.
yeah. And I think what really gives me kind of the safety and confidence to use it is that our national organization for fertility, it's called ASRM, put a statement out saying, look, for patients with polycystic ovary syndrome, PCOS, letrozole works the best and should be standard of care, even if it's not FDA approved. And once I saw that, I said, okay, that makes me feel more
Yeah. And when we talk about safety data and, maybe FDA approval, that's kind of making patients or providers worry about this. What we're worried about is we're giving someone who's potentially going to be pregnant a medication, right? And I think the other thing that's really reassuring about letrozole, it has a very short, what we call half-life, meaning your body processes it and it's out of your system very quickly. And really there's no risk of exposure to the pregnancy or an unborn fetus when you're taking letrozole. Interestingly, Clomid can last a lot longer in your system, at least one of the forms of it. So Clomid can kind of hang around for a longer period of time than letrozole. So something to consider.
Yes, absolutely. And so I guess I kind of jumped the gun a little bit in saying letrozole works best for PCOS patients, right? Because these are the other things we're thinking about when we're deciding, okay, do we use Clomid or do we use letrozole? And that often does come down to the diagnosis, okay? So way back in the very beginning, everybody got Clomid, but in modern day fertility, what we're oftentimes trying to tease out is, could our patient have a condition called PCOS, polycystic ovary syndrome? But even giving this diagnosis is a little tricky these days, right? Because there's so many different definitions or criteria that you can use to diagnose somebody with PCOS. But we'll kind of run through the common criteria that we would use. And probably the most common criteria is made up of 3 different components. The first component is that you have irregular periods or absent periods. The second component is signs of a hormone imbalance where you have too much male hormone. And we can prove this either with blood test or with clinical symptoms like hair growth on the upper lip, chin, or chest, or acne or pimples or things like that. And then the third thing is the ultrasonic appearance of your ovaries. And out of those 3 criteria, you actually only need to have 2 of the 3, but you also have to have ruled out other rare issues that can cause similar symptoms. But if you meet that criteria, I think we both like to go straight to letrozole, right?
Yeah, definitely.
Yeah.
So this is a sensitive subject, diagnosing PCOS.
Yes.
But yes, I review, this is called the Rotterdam criteria. It's probably one of the oldest and most widely accepted criteria for PCOS, but there are a lot of updates to this, right? So ASRM, our governing body, released a huge document on new updates and considerations for diagnosing PCOS. And it is much more complex than we could possibly even explain to you in a consult. And so really when we are diagnosing you and looking at you with a full clinical picture and whether this medication is going to be good for you or not, you should know that there is a lot else that we are considering and whether we think that it would add benefit to your treatment. It's not super black and white to have a diagnosis of PCOS. There's a lot of other aspects that go into it.
Well, and do you mind if I bring up the fact that you were misdiagnosed because somebody told you you didn't have PCOS?
Correct.
And
correct.
You had it.
Yeah.
Right?
So we see this a lot actually. And I just had another patient say this to me this week. Well, my doctor did a blood test for me and she said, I don't have PCOS.
Just off of a blood test.
Blood test.
How is that possible?
Yeah. So you can't rule out PCOS based off a single blood test. And a lot of patients, I think, are relying on these markers, right? And it's just not that simple. It is very complex. And I think missing PCOS can be extremely detrimental because it's something that is going to affect your health for a long time. So when we're thinking about, is letrozole going to be the right medication to get you pregnant, it's also, how are we going to manage you, once we are treating you when you're pregnant.
Mm-hmm. Okay, so if letrozole works better in patients who have PCOS, then what about all the other patients that don't have PCOS? What's going to work better from them? And I will say there are tons of studies going on, but the general consensus is we think that Clomid probably does better for the rest of everybody else. But I will say, although I'll often start with Clomid in those cases, it doesn't really matter too much if you end up switching from Clomid to letrozole in that population, right?
Mhm.
They both do pretty well.
Right,
Yeah.
correct. And that's what really leads us into, what are the downsides of the medications? So, side effects or downsides of Clomid, we might start with Clomid for you, and we don't really like how you responded. So,
Yeah.
Dr. Reed mentioned doing monitoring, right? One of the biggest downsides of Clomid is it can thin the lining. For some reason, this is the one thing that all my patients know about with Clomid. And so they really worry about their lining. I think it must be on Google or Chat GPT when you type it in. They always want to know their lining thickness.
Yeah.
And it can, right? So we want you to have nice thick lining so it's ready to receive the embryo when the time comes and implantation can successfully occur. So maybe if you have thin lining on Clomid, we might switch you over to letrozole. It seems that letrozole has less of that negative side effect compared to Clomid. The other thing that Clomid can do is it can affect your cervical mucus. And so we've talked about this before, but cervical mucus is really important also for sperm and being able to get up to the egg. So if we are not going to pair it with an insemination or an IUI and bypass some of that issue, then letrozole can be a better option as well.
Absolutely. And one thing I just wanted to mention, because you heard me say earlier, sometimes if I have somebody where I gave them letrozole and then their lining was thin and I added estrogen to thicken up the lining later, right? You can do that with Clomid, but we think it probably doesn't work as well, because if you think about the mechanism of action of Clomid, as Dr. K said, Clomid tends to last in your system longer. And the problem is Clomid blocks at the receptor level for estrogen. And so you can give all the estrogen you want to try to thicken the lining, but if Clomid is still blocking those receptors at the lining, it's probably just not going to help. I mean, it doesn't hurt to try it at that point, but more so if I identify that there's a thin lining issue on the Clomid, then I say, look, I hope the cycle works for you, but if it doesn't, let's try a different strategy for the following month. I would estimate probably only about 10% of women have a really thin lining on Clomid. So most people do great, but it is something we're always on the lookout for as well.
Yeah. And the lining on the letrozole is interesting. I have a different approach a lot of times with my patients. And because letrozole sort of, wears off as you get further into your cycle, what I see sometimes is just, it's a time thing, right? Your lining needs a little bit more time to recover, because your estrogen levels will start to naturally come back up, especially locally around the uterus. And your uterus just needs a little bit of time to see that estrogen to grow. So a lot of times we'll let my patients kind of push a few more days with their follicle, and we'll see those levels rise, and your lining stimulates really nicely. But it feels hard to wait to the patient. A lot of times, they really are fixated on their lining. But in most of my patients, I will see their lining recover nicely on letrozole, but not the case with Clomid. If you're going to have thin lining and I really see it happening, it's hard to recover it.
Absolutely. Yeah. Okay. Well, I wanted to see what your opinion is on which has the worst just side effects as far as what a patient would feel from the medication. I will say, I think probably 80% of patients don't have side effects at all to either. Okay. But maybe 20% might have some side effects. And so I kind of thought we could talk through what the side effects are of the different ones.
Yeah.
Should we talk about, which one should we talk about? I'll let you pick.
Well, I just think it's funny because a lot of my patients tell me Clomid is really terrible.
Yeah.
And it's probably because more patients have taken Clomid, especially because a lot of OBGYNs will prescribe it before they even see us. But I personally think of any medication I ever took in my fertility journey, letrozole is the worst.
Really?
Yes.
Tell me, what did you get on
Because
letrozole?
I had terrible hot flashes, and it makes me laugh because I had terrible hot flashes. I have headaches that last the entire day. And I'm not a headache prone person. And you know, when you do get a rare headache, you go through all of I'm dehydrated. I need Tylenol. You know, I need caffeine. I do all the things and you still have the headache 24 hours a day. Your sleep is disrupted. You know, you do feel hormonal. And so it makes me laugh though, because a lot of these are the same signs and symptoms of menopause, because letrozole drops your estrogen level down really low. And so I know I know that I must be one of those people that's going to really not do well in menopause. You know, we have some just warrior women that go through menopause. They're like, what? That was nothing. And I'm going to be the one that's like, absolutely, I need help.
Well, the good thing is, you know, somebody who can give you some points.
Yeah.
I think we'll have to be each other's hormone dealers once we menopause, although I'm already headed that way. So, okay, well, I would have guessed Clomid, because it's actually kind of funny. At my old office location, I even had a sign that said Clomid made me do it. Because I mean, oh my gosh, like it can really cause a lot of symptoms, and some are the same, you know, hot flashes, headache, but mood swings, I think, are such a big one. Did you have mood swings on letrozole?
I'm just already like so moody to my husband that like, I think anytime we were doing fertility treatment, he just had to like just take it. You know, someone has to. I say I like keep myself together throughout the whole workday in front of so many people that someone has to bear my wrath, and it's usually my husband.
Well, I think it's hard because when you're on Clomid, you can be sad for no reason.
Yeah.
You can be mad for no reason. You can be sad and mad for no reason. So if it is somebody close to you, you might want to give them the heads up. Hey, I'm on some meds right now. It's going to get better. And it does. Once it wears off, you feel back to normal and everything. But it might be good practice for pregnancy, though, because mood swings are also pretty common in pregnancy, too. Okay, and then we should talk about the risk of multiples, because that is probably the most serious side effect when you think about these medications. And so what are your thoughts? Just based on what you see, do you think there's a higher risk of multiples with Clomid or letrozole, or do you think it's about even?
I would say actually in my patient population, both of them I think are pretty rare. But like, as you said, I am kind of a ginger doser. So I do get like, you know, a little bit lower rates. Traditionally, I think what people will worry about is the higher dose of Clomid and, you know, purposely trying to induce more than one follicle. You're probably going to have a higher risk of multiples. Letrozole tends to recruit just one follicle at a time, especially in patients who don't ovulate. We call that monofollicular development. So slightly lower rates. The studies kind of have a crossover when you look at the data on this, you know, so letrozole, maybe 7 to 8, you know, up to 7 to 10 in some studies, and Clomid can be up to 10%, even 11% in some of the studies, and then lower. So they do have a lot of crossover in the intervals. So I think it's kind of minutia, honestly.
I do remember when people first started using letrozole, one of the big selling points is they said it had a lower risk of multiples compared to Clomid, but they later disproved that, and they said, no, really, they're about the same.
Yeah,
so.
that's what I think. It's
and
just
I
too
feel
much.
like that's what I see too. I think overall too. But for some reason that reminded me, another reason sometimes I'll give letrozole over Clomid is if I know or suspect they have endometriosis or adenomyosis. These are conditions where little bits of your lining may implant in different spots where they shouldn't be, like in the pelvis or in the muscle of the uterus. And interestingly, we think these little implants can actually make aromatase, and letrozole is an aromatase inhibitor. And so although this hasn't been proven, this is me just trying to use logic. Sometimes I'll use those medications because I'm like, maybe that'll help kind of reduce activity at the site of those implants as well. Again, I don't think Clomid's a bad choice. I also use Clomid in those patients as well, but sometimes that'll be something to think about too. Also, I wanted to bring up one of the big side effects they teach us about in training for Clomid that we really have to be on the lookout. We don't see it very often, but do you know which one I'm talking about?
Visual changes.
Yes.
I've never had it. Have you had it happen?
No.
Yeah, I've
well,
never had a patient
actually,
happen.
no, I take that back. Yes. Every now, I would say maybe once every year or two, I'll see it happen. But, you know, they warn us if somebody's having visual changes, they need to stop the medication right away and don't give it to them again. Because if somebody is having that side effect, you do worry, could it progress to some sort of blindness or something like that? Now, it's more theoretical. This hasn't been proven or anything, but we are all very sensitive to that because of our training. And so if you say the magic words, which is, my vision is blurry or I'm seeing flashes
Mhm.
of light or something with Clomid, then you don't get to have Clomid
Yeah.
anymore.
You get a big red note on your chart.
Yeah, yeah. Okay, good. Well, should we wrap it up?
Yeah.
Okay, perfect. All right, thank you guys. We really appreciate you guys listening. If you have time, we'd really appreciate if you left us a positive review, either on our Peak Fertility clinic page under Google or just for our podcast review. We'd really appreciate it.
Have
Thank
a good
you.
week.
Bye.